Hello, everyone. I've been told to give a couple of seconds while everyone's joining, but you should be on now. So, excuse me. Welcome to you all. I believe there's nearly 200 people on this webinar on innovation and patient safety during COVID. So welcome to you all. Fantastic that you're joining us. Couple of housekeeping. We've got a good 20 minutes at the end of the presentations for an active Q&A and discussion. So as I put in the little chat box there, do put your questions and comments as you go through, and we'll cover as many of those as possible. So we'd like this to be as interactive and engaged a presentation as possible. You'll also see on the right-hand side of your screen, files, slides and offers. All of that information is readily available to you. So if you've got any questions about, can we have a copy of the slides? What about the resources that are being talked about? They're all available there for you to access. So that's going to be available now and after the webinar. So I'm not going to introduce colleagues at the very beginning. They're going to introduce themselves as we go along, because we're going to try and keep the presentations quite tight. And I'm going to start with my presentation. I'm Chief Exec of Patient Safety Learning, which is a charity that promotes knowledge sharing and improvement for patient safety and reduced harm. So next slide. And I'm just going to provide a little bit of context. Most of you on the call will be healthcare professionals and will understand the issues and challenges of patient safety. And this slide kind of sums it up really, about patient safety being, by WHO, one of the world's top 10 leading causes of death. I mean, that is just astonishing. And as we know, that many patients that are harmed in hospitals and primary care, much of that unsafe care and harm is preventable. The UK identifies that about 11,000 avoidable deaths a year, each one a huge personal tragedy. But there's also a tragedy across the whole system, is that we are wasting money doing the wrong thing. So OECD suggests 15, possibly even 25% of everything we spend on healthcare is a direct cost of unsafe care. So if we start doing the right things and designing safe systems, we will not only be improving the safety of patients, improving the safety of staff, but saving money to do more of the good stuff that we need to. So next slide, please. So what we've done as a charity, we've only been going less than 2 years, is start thinking about, well, we've known about unsafe care and the causes of harm 15, 20 years ago. So why is harm such a persistent problem? When the memory was published in 2000 and about just out 2000, 2001, we thought, those of us that were working in patient safety at the time, that understanding and that knowledge and the programs that have been developed over those years would lead to significant reductions in unsafe care and harm. And it hasn't had the scale of improvement that we've seen in other industries that have tried to tackle this. And we've tried to reflect, as Patient Safety Learning, why is it a persistent problem? And the core thing, I think, is the punchline there. Safe care must be a core purpose. It must be core to everything we do. And part of the theme of today's presentations about innovation and safety is having safety at the core of our decision making. We're concerned that safety is one priority of many, and it tends to get juggled, and sometimes access targets or financial targets take priority. And we don't think in Patient Safety Learning that we have enough formalised standards of good practice that we should work towards, and we're not using those to inform and design safe systems. Some examples of how we're addressing that will come out through the presentation. We operate health and social care not just only in the UK, but internationally. There's a big blame culture and fear culture that prevents us from learning and engaging staff and indeed patients in the safety of their care. And we don't think leadership is sufficiently engaged in promoting safety and taking the leadership role for safety as a core purpose. Core to that is that we need, when things go wrong, we need to learn and act on that learning, and we need to share the good practice. Go forward. And one of the things, so we, as an organisation, we don't want to be just writing policy papers. We want to contributing to improvement. But what we have done is we published last year what we've described as a blueprint for action. So we've reflected on that, those core foundations of patient safety. How do we address the persistent harm? And we've identified above and beyond the kind of clinically focused safety improvement initiatives. Many of them are led in the UK, many of them through WHO, but we've looked at the foundations that would enable health and social care to be a safe system. I'm not going to dwell on these. We really need to listen to the webinar speakers, but you'll see from the resources that we've shared at the end of the slide where you can access our blueprint for action. And this describes what a safe system should look like, learning from other industries and improvements in health and social care elsewhere. Excuse me, and distilled it down to these 6 foundations around leadership, about sharing learning from when things go wrong, from when things go right, how we need to professionalize patient safety with expertise, better understanding around human factors and ergonomics, and ensuring that everyone that contributes to health and social care, whether you're a porter, you're a healthcare worker, whether you're a non-exec, whether you're a specialist leader, everyone needs to have the knowledge to contribute to a safe care. How we engage patients in their own care and if things go wrong, and in advocacy, and getting the data and insight and metrics to help inform us is core. But core to it all is having the just culture. And I'm seeing that we've already got some comments on that. So thank you very much already for people that are highlighting how important that just culture is, and just and fair culture. Next slide. So one thing I'd like to share with you, and it's pretty much the slide before last, is one of the active things that we're doing as well in patient safety learning is helping develop safety standards and thinking about developing an accreditation framework for patient safety at an organisation level. We launched last October a knowledge sharing platform for patient safety. We felt from the research that we've done and the insights that other industries, how they apply learning, we needed a place that is free for anyone to use, whether you're a clinician, a researcher, a leader, a patient, a member of the public, anyone, where you can find knowledge about a patient safety. You can find knowledge that will inform you. You can share knowledge, that your own insights of what you've learned from when things have gone wrong, but also when you're making improvements and there are innovations. And we have designed and launched last October, we call the Hub. And this is kind of the launch page. The details are later. It's free for people to use, and we welcome everyone engaging in sharing that learning and joining in communities. So demonstrating that we can improve and improve by sharing for safety. Next slide. So what we're asking, my last slide, what we're asking, please join us on the Hub. It's free. Learn, share, join the community, become a topic expert, share your experiences, your innovation, find out more, share with us and through us to others both in the UK and internationally. Since we launched last October, we've had 43,000 people viewing us. We've got over 1,000 registered members with a zero marketing budget. We're in 35 countries and 350 organisations within the UK are participants. So please join us and I welcome you in that. Now I have the great privilege today of chairing today's session and introducing some fabulous speakers that will be taking a case study based approach to innovation and during COVID-19. And I'm going to start by introducing Stuart, who's the Managing Director of Pentland Medical. And Stuart, a few minutes for you, a bit of the background on the company and the story behind why we're here today and the idea of why we felt this webinar was valuable for sharing innovation and safety improvement.
Well, thank you, Helen, and good afternoon, everybody. Thank you for taking the time to join us on this webinar today. I spent 12 years working with leading British manufacturers of clinical investigation systems, from cerebral function monitoring to GI motility and ambulatory physiological recording. I spent time in sales and development of these products and also customer support worldwide. That experience taught me the value of safety in the general clinical environment. Obviously, patient safety being a very valuable component of that. But actually, they're all intertwined. So it's patient safety, staff safety, and confidence in the whole clinical environment, I think, is an essential part of any successful product introduction to healthcare. I started Pentland Medical 23 years ago with a mission to introduce new innovative ideas and solutions to the UK healthcare market. And in that time, I think we've been instrumental in improving patient safety and clinical outcomes. A couple of examples I can give you would be patient eye protection and blood saturation measurement during anesthesia. I think there's 2 products there, but we've actually transformed the outlook of patient outcomes and now have a much better awareness of what sometimes can be very innocent looking problems. People don't actually understand that rolls of tape in the clinical environment are actually such a damaging item that we could actually just get rid of, and everything would be improved by replacing the tape with a better solution. Quite simple, but actually it has a dramatic effect on patient outcomes, and we can obviously you can go on our website and see some of that information that's available to you. Despite over the years working with organisations like NICE, who were very successful and very positive experience in the blood saturation, oxygen saturation device, in issuing a MedTech innovation briefing that actually not only outlined the clinical benefits, but also explained where it's cost effective, which is obviously a very important factor for the NHS. Despite this, the sales didn't increase. The reality is that even with all that easy information available to procurement, they don't actually process that. They're more interested in focusing on something that will actually reduce an existing budget, i.e. a cheaper product identical to one they're currently buying. Our success is generally due to hard work and just identifying with expertise over the years these places that will adapt and adopt new technology. And that has actually been more. It's taken a long time to get many of these products into these hospitals that actually survive, make the business a survivable actual business model. None of the plethora of other organisations and schemes over the years invented by the NHS, we've engaged with every single one of them, and none of them have actually made any difference to our sales. It's all about working at local level. So it can be done, but it is a hard slog, and we sometimes feel like we're missionaries on a sort of unwanted mission. So it's something we're passionate about, and hopefully that will come across in today's presentation. The experience with Monodrop over the last 18 months that you're about to see today echoes exactly what we're saying. We engaged with the latest Accelerated Access Collaborative Programme and registered Monodrop about a year ago with Health Tech Connect, which is the gateway used by the collaborative. And initial reaction was very good. We got a positive, rapid response, and we're engaged quite quickly with a couple of HSNs. But they've actually has not been any positive effect from that at all. The difference has arisen because of the Covid-19 situation, and you'll hear today a case study that will kind of feed into the whole process. But the basic result of the identification that COVID was likely to leave many trusts without sufficient IV pump requirement led to a number of trusts who were already aware of the technology and had already been trying to get them to buy, contacting us urgently and asking us to provide a solution for them. That's led to the installation of several hundred units in 5 different trusts. We're very proud and pleased about that. Subsequently, we were contacted by the government-led initiative, or government led by Deloitte, to address this issue nationally, kind of like the ventilator thing as well. They're looking at these issues where there could be a serious problem due to the volume of patients coming in on the COVID crisis. We put a case forward for monodrop to be adopted as part of the solution on that as well. We're very forceful in warning Deloitte that if they buy infusion pumps and they're not used, they will require maintenance and support from EBME. They will lie in a cupboard, but that's it. You know, and monodrop would provide them with a much better solution going forward, with much more versatility, low cost, and lots of other advantages. But they basically ignored that as well. So we're not very pleased about that, and we're actually looking into reasons that could have been maybe improved. Unfortunately, it feeds into the rest of what I've been saying, is we don't have much success at all with any of the schemes and national sort of bodies on our innovative products, but we can tell you many happy customers that can actually verify what we're saying. I think that's enough from me. I'll put you forward to Jamie now, who's going to give you a presentation on what monodrop's all about. Hopefully you'll see there are many advantages and obviously follow up from there with our special offer. So over to you, Jamie. Thank you.
Yeah, thanks, Stuart, and thanks to everyone for joining in today's webinar. My name is Jamie Munro. I'm the sales manager for Pentland Medical. I guess my role in the presentation is to give you an introduction to monodrop itself, starting by discussing manually given IV therapy, how frequent errors are when manually given IV therapy is a method used to administer the fluids, and also some of the complications that can arise from this. I'll also discuss the role of volumetric pumps before I introduce monodrop and show you where it sits in the current marketplace as a monitor of IV fluids. Furthermore, I also have some add-ons to show you that are available with the monodrop device, such as the remote monitoring software platform, as well as the IV sets that we're going to be selling later this year, designed to work specifically with monodrop. So just before I get properly started, I know Helen mentioned it at the start there, there are several documents available for download in the files section. You can download them throughout the webinar, but I'll be referencing them throughout my part of the presentation. I'd like to start by pointing out the promotional literature, in particular from the manufacturers and from Pentland Medical, as well as a written research article specific to the monodrop itself. So can we have the next slide, please? Okay, so still in 2020, infusions are manually administered on the wards without accurate settings, and the infusion information is entered onto the patient's records with paper and pen. Think about how different this picture would look if we had a drop counter attached to the drip chamber. The nurse would have so much more time to observe and talk to the patient. Next slide, please. So manually given IV therapy is inaccurate and prone to errors. The infusion may run too fast or stop suddenly without any warning, which poses a risk to patient safety. This graph shows the results of manual IV therapy accuracy. Nurses try to set 200 mL per hour, manually calculating drops as they're taught in their nursing education. Actual results were then measured with the monodrop. The results varied a lot, and this picture shows that it's not easy to set infusions accurately. Only 31 out of 129 nurses could reach within 12.5% accuracy. Monodrop has even better accuracy at plus or minus 1.8%, and if the administration set is one of the better sets available, then a total of plus or minus 3.8% accuracy can be achieved. And this is close to or at the level of a typical volumetric pump. They can be about plus or minus 5% accuracy. So please observe both extremes when patients don't get enough or too much fluids, as both of these scenarios are potentially dangerous to patients. There is a research article available for download, which highlights the frequency of errors in IV fluid administration with manual giving sets. Next slide, please. So the NICE guidelines for intravenous fluid therapy in adults in hospital, published in 2013, updated in 2017, highlighted the issues relating to poor fluid therapy management. Inaccuracy in infusion therapy can lead to complications. Over-infusion can lead to pulmonary edema, cardiac failure, and electrolyte disorders such as hyponatremia. Other fluid imbalance related problems are caused by not infusing enough fluids, which in extreme situations can result in hypovolemic shock. All of this can add to a longer hospital stay and even increased mortality. Next slide, please. So volumetric pumps are the gold standard for administering IV therapy. They allow nurses to set the speed of infusion and the pump will control the fluid administration thereafter. Pumps are critical for some fluids, medications, and in certain scenarios. However, there are several issues, meaning pumps are not always practical. The purpose of MoniDrop is not to directly replace pumps, but as an ideal solution for infusions where a pump is not absolutely necessary or practical. For example, there is research available that shows the potentially negative impact that the pumping mechanism can have on red blood cells. Another potential downside to infusion pumps, particularly at this time, is the effort and time required to effectively clean them. One issue that was really exposed when the severity of Covid-19 became apparent was the shortage of pumps in many hospitals. Even before the pandemic, pump shortages were common, with many hospitals not adequately covered. But this was generally overlooked until the situation became so severe. As Stuart touched on, we are led to believe that the government subsequently sourced infusion pumps, which are available to trusts nationwide in the event of a high number of infections leading to strains on capacity. However, there are concerns that these pumps are not the standard that many trusts are used to. Additionally, any new pumps coming to the hospital require a lot of training for a lot of people, and the necessary skill level can be difficult to maintain. Pumps do require a lot of maintenance due to all the mechanical parts inside, and this comes at a cost both in time and money. And furthermore, dedicated pump administration sets are required for each make of pump, and these are generally far more expensive than a manual IV set, which are universally used with the MoniDrop. Next slide, please. So we're just about to play a video which gives an overview of MoniDrop and the associated remote monitoring software application. But we want to position MoniDrop as a missing link to bridge the gap between manually given IV therapy and the absolute requirement for a volumetric pump. As highlighted earlier, manual IV therapy leads to inaccurate infusions, which can compromise patient safety. To increase safety, volumetric pumps are used in specific situations for administration of IV therapy, but this method is not always ideal or even possible due to shortages and other impracticalities. So yeah, if we could now just play the short introductory video, which gives an overview of MoniDrop and the associated remote monitoring software platform.
Remote monitoring for infusion therapy improves patient care management. The MoniDor solution consists of the MoniDrop device that assists the user to adjust the required infusion rate with the roller clamp, and the IV screen remote monitoring software application, which displays the status of infusions for every MoniDrop device in use. To use the system, switch on the device by pressing the power button. Attach the MoniDrop device to the drip chamber. Adjust the required infusion rate with the roller clamp. The device displays the accurate flow rate. The MoniDrop displays the total volume infused and the total treatment duration. The MoniDrop device doesn't adjust the infusion rate. Fluctuations in the infusion rate are normal if the patient moves. The audible occlusion notification can be turned on by pressing the notification button. When the MoniDrop is switched on, the device data appears automatically to the remote monitoring IV screen. Each device has a unique ID number, which helps to identify the device on the IV screen. On the IV screen, each device can be assigned to a room location and to a patient's bed number. There is an option to set the target values for the fluid volume to be infused and the treatment duration. MoniDrop has a rechargeable battery, and this can also be used at the time of charging. Switch off the device by pressing the power button for 3 seconds. Clean the device, for example, with a disinfectant wipe. Monodrop can be used to administer maintenance fluids, antibiotics and medications, blood products, and nutritional solutions. Monodrop fits most gravity administration sets. For more information, please read the instruction manual and visit our website.
So yeah, if we could have the next slide up. That's the one, yeah. So Monodrop can assist nurses in infusing blood, nutrients, antibiotics, some chemotherapy, pain relief, and miscellaneous medications. In the download section, there is a user guide of fluids and medications suitable for administration with the support of Monodrop. To name a few: platelets, white cells, red cells, iron infusion, vitamin B, normal saline, tramadol, cortisone, plus many more. It is important to highlight that these are simply examples of medications and infusions that Monodrop could be used for. The items mentioned and included on the list are dependent on the speciality, and the decision to use Monodrop must always be made by the clinicians and pharmacists. Next slide, please. As we showed on the introductory video, the Monodrop devices have the ability to link up to the IV Screen remote monitoring software platform. With IV Screen, all infusions where a Monodrop is in use can be monitored from a central ward computer or a mobile device such as a laptop, tablet, or smartphone without the need for alarms. This is a big advantage, particularly as patients are not disturbed at quiet times or during the night. The only time Monodrop will alarm is if there is a potentially dangerous occlusion on the line, or worse still, a constant flow of fluid. IV Screen will display the current speed of each infusion, as well as the total volume, target volume, and the duration of the infusion. The full potential of Monodrop can be realised with IV Screen, as nurses are given the increased functionality of being able to set a desired volume and duration of each infusion, which automatically calculates the appropriate speed. All infusions in the ward that are running at the correct speed will be highlighted green on the computer. However, if infusions begin to run too fast or too slow, it will turn to yellow, prompting the nurse to adjust the speed on the IV set. IV Screen has the potential to greatly increase staff efficiency and patient safety. We have some written testimonials available in the download section. Next slide, please. So there are a variety of gravity IV sets with roller clamp available. Some of them are better quality than others. However, generally speaking, they're not very good at holding a consistent speed for longer periods of time. Another type of set in occasional use are dial flow sets. They attempt to control the speed of the infusion with a dial. However, many hospitals have forbidden their use, as there is a lot of bad press concerning their accuracy. There is a research article available in the downloads section which highlights these problems, but in summary, the numbers printed on the dial do not reflect the actual flow rate that you get. However, dial sets do have a positive side. The mechanism used in the dial set to adjust the IV tubing and ultimately dictate the speed of the infusion is much more robust than the pinpoint wheel mechanism used in a standard gravity IV set. This leads to a far more consistent speed of infusion, less affected by movement or other outside factors. While the actual speed actually coming down the drip chamber is different to what has been set on the dial, it will consistently stay at that speed. Next slide, please. So just on this slide here is a great addition to the overall Monodrop package, which is the economic flow regulator sets. These will be available later in 2020, specifically for use with the Monodrop device. These are essentially dial flow giving sets. However, there are no numbers printed on the dial, and users would instead take the reading from the Monodrop screen. So basically, we're taking the positive from the dial flow set, and that will keep a consistent speed without having to worry about the inaccurate drop rate. Initial testing on these sets has shown that it can hold a consistent speed for far longer periods of time than you would get from a manual IV set. Combine this with the remote monitoring, and we're providing a unique solution which will be more practical than pumps in many circumstances, without all the problems associated with pumps. Furthermore, we will provide a specific blood giving set, meaning that blood transfusions can be done with a much greater level of accuracy and patient safety than you would get from a gravity set designed for blood transfusions. So next slide, please. So yeah, just to finish off my part, we're going to now play a pre-recorded testimonial we recently filmed on site at West Suffolk Hospital with one of the nurses currently using the MoniDrop device, before we hand over to Dylan from the EBME department at West Suffolk, who's going to describe their experiences concerning infusion devices at the start of the pandemic. I'd also like to take this opportunity to inform everyone of a special offer we are running as part of this webinar. If you inquire with Pentland Medical throughout July, quoting the code on the screen at the moment, IVScreen 2020, we'll offer a 10% discount on any eventual purchase of MoniDrop. This will include a trial of the IVScreen remote monitoring software application. So thanks for listening to my part of the presentation. I look forward to some good discussion later in the webinar, and if we could just finish off by playing that final video.
My name is Laura Lewis. I am a staff nurse at the West Suffolk Hospital in Bury St Edmunds. We started using the MoniDrop device approximately 2 months ago. We find on the ward that it's very useful for independent patients who are using mobile drip stands because it's a lot lighter, it's not as heavy as the infusion pumps. We find that also when someone's independent and they're moving their arms a lot, that the rate for the alarm to go off is like 3 minutes rather than instantaneously, so it saves us a lot of running backwards and forwards to reset and restart, so it works well for that. We find that also they're very useful for calculating drops. Me as a reasonably newly qualified nurse, I find that when you're using the gravity feed, you have to use the dossiflow to calculate the drops, and if you're just guessing, it's quite difficult for someone like me, whereas with the MoniDrop I can use that to get within the range and it works perfect, I find. We've used on many ranges of different fluids. We use it through Hartmann's, we use it for sodium chloride and glucose. The only fluid we don't use for is the potassium. As for IVs, we use it for the antibiotics, so things like tazocin and clarithromycin, Pabranex medication. We use it for a variety of things, and we use it on a daily basis. We find it works very well. Drop helps with the Covid-19 situation because it's situated on the ward and it's easy to be cleaned. We can use it as and when without calling the porters to bring down infusion pumps to basically save people coming on a ward where it's, you know, a high risk. The MoniDrop device is so much easier. With an infusion pump you give it an outside clean, then you have to send it away to be specially cleaned, and then you have to request them every time you want one. With the MoniDrop we can just take down, we clean it with the wipes, they then go back on the stand and put on charge, so they're available all the time for us. It's just easier, it's a lot lighter, a lot quicker to set up. The only time I tend not to use the MoniDrop if the medication has to go through at a certain time, then we use the infuser, so obviously it's pushing the fluids and pushing the medication through. Otherwise we do tend to use the MoniDrop. It's just a lot easier, a lot kinder and a lot safer because they're not so heavy for the patients to have next to the bedside. I find it's freed us up quite a bit with the alarms going off, because with an infuser pump, it literally, as soon as it's occluded, it will alarm, so you're constantly at the bedside stopping the inclusion, restarting, whereas with the MoniDrop it gives you a 3-minute window for an alarm to go off. Someone could bend their arm if it's put in a bit of a awkward place, the cannula started in an awkward place, so it just frees up the nurse's time. I have trained many of the nurses up on the ward on the best way of using the device and how to set the settings for the alarm to go off, the range in which it will allow it to change. So yeah, most of the nurses now are quite confident with using the monodrop on the ward. I would recommend monodrop because I find it very useful and quick and easy and at hand. It's very good for our patients and frees our time up to concentrate on what we're meant to be doing. I think the use of monodrop could be improved by having that remote central access point of the tablet, so we can monitor all the patients which are using the monodrop, find out where they are in the therapy, and then keep a close eye on when everything's going to end, so we can effectively plan our day better. And I think that will be a big help.
Hello, my name's Dylan Goten. I'm the EBME team manager at West Suffolk Hospital. Next slide, please. I first encountered the monodrop at the EBME Expo in summer of 2019 at Milton Keynes. I was impressed with the concept of the device, where it was allowing the nurses to perform gravity-fed infusions, but providing the accuracy of an infusion pump. I liked the design of it. It was eye-catching, it was smart and sleek, but most of all, I was really impressed with how user-friendly it was. It was a basic and functional interface, but it did everything it needed to do. I was also impressed with the intended usage of it and the realization that volumetric pumps were being used for infusions that this device could easily replace them for. You don't need an infusion pump for many of the infusions that were taking place. This then was the right tool for the job, freeing up volumetric pumps in the hospital for where they were more needed. Next slide, please. We have a medical equipment library at our hospital, as you can see from the little picture there, which is how we manage our stock of equipment. Among the items we keep are the volumetric pumps. These are always in demand in the hospital, and throughout last year we were very often running our stock down to zero at busy times, but almost every Monday morning when we came into the library there would be no pumps left. That was then compounded by winter pressures, so we requested some loan devices from a regular supplier and they provided us with 15. However, that loan was just about due to expire when the COVID pandemic hit us and really started to have an impact on us. And the pump supplier was apologetic, but they really needed to recall the devices. There was nothing they could do about it. So we looked into what options there were. We contacted several of what we consider to be reputable pump suppliers, and no one had any stock that they could give us. So there was more of a need to look into wider options. It was then I remembered seeing an email advert where Pentland had followed up with me from the EBME Expo, and I decided to get in touch. I thought it would be a good fit to ease up the pressure on the volumetric pump, so I started having some chats with the relevant people, the managers and ward managers here. So I had a chat with Pentland, and luckily they had 10 devices that were able to loan me to evaluate them. Next slide, please. So the trial period started very quickly. Pentland were fantastic in getting the devices into me very rapidly within a few days, and also arranging the training requirements within a few days in those challenging circumstances early on in the pandemic. I was concerned that there might not be a big uptake on them because it was a new concept to the clinical teams. However, thankfully, I was proved wrong. They were an instant hit, and we got positive feedback from each area that we put them into, mainly based around user friendliness, not having to acquire an infusion pump, and also the fact that they were simpler to set up and use than an infusion pump. And also a later point is what the nurse mentioned in the video, that they're also easier to clean than the infusion pumps. When I had to remove some from certain areas, the staff were very reluctant to let them go. So overall, it was a positive experience, and we very quickly arranged the purchase of 30 devices. As COVID has started to calm down, we've realised the value of these devices within our hospital for easing up our use on volumetric pumps. And so we've increased the number of units we have to 50, spread over some of the original areas we trialled them in, and also our ITU. So we now own 50, but we've currently, as we speak, there's a trial going on in our labour suite where they're evaluating them there with a view to possibly purchasing some in the near future. So the key point really is the fact that it makes gravity feed infusions safe and accurate. So that's the end of my presentation. Thank you.
Thank you very much, Dylan. And now it's down to a discussion session, and we're absolutely on time, which is very unusual with my chairing. But thanks to everyone for keeping to the time slot. So we've got about 20 minutes for comments or questions. We've had a couple coming in, so I'll pick on those. But I'm going to choose going to reflect back on something that Stuart, I think you mentioned, was that trusts are finding values in such products. So you're engaging directly with trust on these products, but the engagement with the innovation tier around AHSNs, it has been less of a successful one. And I wonder whether you've got any reflections on, a manufacturer introducing a new technology, a new product that will improve efficiency and safety, how that route to getting access to the market, your reflections on that.
Yeah, it's a good question, Helen. I don't want to be negative because I actually have a great respect for the fact that the NHS is a huge task in management, and I don't want to underestimate that for a minute. The Accelerated Access Collaborative that was introduced last year did look to be very promising to me in the sense that for once it was drawing together every single body involved with innovation in healthcare in the UK, that is. But the reality is, I think when we've engaged with it, we get punted from one section. There's a culture still in the NHS. I think it's developed over many, many years where there's cynicism and there's not a lot of appetite for the work involved in introducing new technologies. And I can understand that from the user's point of view. Perhaps, I'm not actually sure. I like to propose solutions, but I'm not actually sure in this sense what might work. The collaborative looks good on paper, but perhaps if it was actually just one body we had to deal with that had the best elements of every body in there put together working in unison, we might find that a better experience. In monodrop terms, we basically spent the time hearing things that we already knew and being asked to spend a lot more time and money on clinical evidence, when I can guarantee you 20 years ago, 30 years ago in the NHS, we had such great success with fantastic everyday accepted products now that people would never dream of operating without, because hospitals were able to embrace the technology, get them in, and prove for themselves that they worked. In many, many cases, as long as you have good support in terms of implementing new techniques and products, it's the best evaluation you can have.
I just wonder. Thanks, Stuart. I was just wondering if Dylan, you'd want to come in and comment on that, because you're on the other side. You're on the trust side and having to make those decisions.
Well, we're not too bad in this trust for that. As long as we can get someone to look at the devices, and obviously we check them over to check that they're suitable, then people are reasonably minded here. If anything, we've got more of an issue in us as EBME to make sure people don't bring in stuff that isn't appropriate. So.
Okay, thank you. I've got a few questions. Some of them are about the product itself, and then some of them are about the product in use, if I may kind of look at it that way. There's a question from Heather who asks, can the product be turned off? Can it be locked to reduce patient tamper?
Yeah, I mean, it can't really, no, it can't be turned off as such. I mean, there's only two buttons on the device itself. It can't really be tampered with. The only way, it could be tampered with is if they actually played with the infusion set, which they would do. If they were going to do that, they could do that anyway, regardless of whether they had a money drop. The good thing about having the money drop there is that it's going to alert you if there's an occlusion on the line, or if there's a constant flow of fluids, whereas you wouldn't get that just on a normal manual IV set. And if somebody's been tampering with the IV line, the nurse might come and see that there's a constant flow of fluid, and then panic stations after that. So the money drop is going to have an audible alarm if somebody has been tampering with it. As for tampering with it itself, there's not really much you can do that would have a negative impact. And if you have the remote monitoring software application, which I talked about earlier, that's all controlled from a central computer, which only the nursing team would have access to, so that there's not really any risk there in terms of tampering with the device.
Okay, thank you, Jamie. I've got a question from Marku, who says, interesting presentation. What are the actual savings you can make by using MoneyDrop instead of volumetric pump sets? I don't know if that's part of the resources that you've already got on the files for people to look at.
I don't think we've got any specific resources, but I mean, I kind of alluded to in my part of the presentation, the pump administration set. So if we're talking about consumables, there's also the capital cost as well. An infusion pump, the sort of top range ones are much more expensive than a MoneyDrop device. But in terms of consumable cost, a pump administration set on average £2 to £3, depending on the type that you're using. A gravity IV set, 40, 50 pence on average. So each time you're using a gravity set instead of a pump set, you're saving money. And if you think of the number of infusions that are done on a daily basis in the hospital, that mounts up quite significantly. Also there's other considerations. There's the maintenance. I mean, Dylan will be able to vouch for this one, is the maintenance required for the infusion pumps, the amount of time that the EBME team will spend fixing the pumps if there's something wrong with it. Due to all the mechanical parts, MoneyDrop is very simple by comparison. There's no mechanical parts. All it requires is a battery change every 2 years. So very straightforward comparatively.
There is a handout on the uploads of an article I've written that goes into cost comparison amongst other little bullet points. So that's available to you on the documents uploaded.
Okay, thank you. Thanks, Stuart. And no doubt, people can contact you directly afterwards. They've got the contact details if they need to follow that up. Now, we've got Claire Cox has raised a number of issues, so we might need to do this in sections. So she asked the question, do trusts have to buy the software for this? So let's start with that one.
No, it can work as a standalone device. As I touched on in my presentation, that's where you can realise the full potential of MoneyDrop if you have the software as well, because you're allowed to set the desired speed of infusion, and the nurses can monitor all the infusions centrally. And if it starts running too fast or too slow on any given device, it's going to alert the nurses to that. And prompt them to change it. Whereas if you're using it as just a standalone device, I mean, the information you get on the screen here, you'll not be able to see it here, but basically it would just tell you the speed that the infusion's running at, the total volume infused, and the total time. And it's only going to alarm if there's an occlusion or if there's a constant flow of fluid. So as I say, the full benefit of the system would be in remote monitoring. But no, you can use it as standalone as well. As a short answer.
Thank you. And I think another question she's asked is about patients in hospitals getting sicker, and the MoneyDrop machines on one patient potentially could be confusing for the user. And by user, I think she's suggesting the nurses, and that you may have lines mixed up if you're using multiple MoneyDrops. So actually making that comment, but I think it links into her question at the end, which is about the user testing involved in use, particularly where you might have multiple infusions, and whether that user testing has involved a human factors expert. So a number of issues to raise there for you, Jamie.
Okay. Yeah, I mean, it's a fairly new technology, the software. I mean, it's something I'm not entirely sure if there's been human factors experts involved with it. As I did point out, there is some testimonials available for download in the document drop section for this webinar, which gives some user feedback on that. But yeah, it's a very good point, actually. If you were using multiple, I mean, if you had multiple infusions running on a single patient, I think is my understanding of that question, and the potential for lines to get mixed up. It's a good comment. I mean, certainly the way that I've been promoting it since we launched it was really, just having, one device monitoring multiple patients in the ward. So you would have on your screen, patient A, patient B, patient C, and but I guess I've not thought about it too much in terms of if you had multiple devices on a single patient. I guess if we're not really advising that it's always used in the real critical areas where you would have a lot of, a lot of pumps, for example. As I was saying, we're not trying to directly replace pumps. You'll never replace that. In certain circumstances, certain drugs, you're going to need a pump, and monodrop's not going to do everything. But certainly for those infusions where you don't need to use a pump, but you need a better level of control, that's where we're sort of pushing it. So yeah, I would have to get back on that in terms of if there's been any human factors experts.
Well, I might, thanks, Jamie. I might ask Dylan if there's any comments he would want to make specifically on the issues raised by Claire, but in terms of how you and other EBME experts in the NHS, how you undertake that user testing, or do you get human factors experts involved? What's the way that things happen at the moment?
Well, I wouldn't. We don't get human factors experts or anything like that. We look into the use of the device, and there are occasions where we'll look at it and we'll spot something where we think actually that wouldn't be that safe for the patient to use that, and we'll prevent it from going into use, even if the user wasn't keen on trialing it. Because we've all got responsibility for safety in the NHS. So, so we do consider that, but also when we brought the monodrop in, for instance, they were trained by the company, so the intended use of it was explained to the staff, and it's being used in areas for infusions where it is solitary infusions. And as Jamie said, it tends to be in the more critical areas where you get banks of infusion pumps delivering different infusions. And I think, so the thing is, but the types of infusions they're receiving that are probably mostly the ones that you would use a pump for regardless, I would think. So, I mean, for instance, our ITU have taken some monodrops and are using them, but it's for patients who are at the later stage where they maybe only need one infusion. So, and as Jamie says, this isn't intended to replace infusion pumps. It's intended to ease the need of them, and only using volumetric infusion pumps where they're actually required.
Yeah, thanks, Dylan. A question from me, if I can be cheeky enough to do that, is how do you and your colleagues across the NHS coordinate in terms of that insight? If you've got an experience with a new product, a new innovation, and you're getting some success out of it, do you is there a kind of informal network? Is there a knowledge sharing network for getting insight from colleagues, getting advice? This works. Avoid this like the plague. How do you all coordinate on that?
There's no real. If there was something that you were going to say avoid like the plague, the chances are you would raise some sort of incident on it that would go to the MHRA and people would find out about it that way. Certainly I've found out about equipment that way that I've heard was maybe had a possibility of coming into the hospital, and I've looked into the details of the device and then found out, hang on, that we've been warned this isn't a good device. There is a website called ebme.co.uk that you can actually anyone can look at the forums on it, I believe. I don't think you need to be a member to put stuff on, but you don't need to be a member to look to see what people have discussed. So that's also a good area. But there are also some user groups, medical equipment. For instance, my manager is the medical device safety officer, and he attends national, regional meetings to do with equipment safety. So that would also be picked up there. But as for, as maybe something that could be slightly lacking, is those are for negative feedback on devices. Whereas if you have a really positive experience with it, you know, fair enough. I'm originally from Glasgow, as my accent gives away, but I'm now living and working in Bury St Edmunds. But I occasionally speak to some of my colleagues from Glasgow, so they could maybe pick up some stuff from me, but it would all be informal. There's nothing. And I believe EBME might be reluctant to put something like that on the forums because it would be tantamount to people trying to sell it, if you know what I mean.
Yeah. I think if I can give a reflection, I think it is this area where it's quite difficult, where you're introducing a new concept or a new product or a new innovation, and you know, being seen to be promoting a particular product, and you know the potential conflicts around that on procurement, but you can see my interest in this because I've talked about the hub that patient safety learning provides, and there don't seem to be very readily available places where people could share knowledge of good practice, not perfect practice, not an endorsed you must buy this product, but just, hey, this has worked for us, have you thought about it? And maybe that's something that, Dylan, we could talk a bit more about, and maybe we on the hub could help in some way. But anyway, that's a separate point. But as you say, the focus often is on the negative rather than the positive in safety. Stuart, did you want to comment on that?
I think it's a very good point, actually, and I think an example of one medium that's very successful for us and has been in the past is conferences and our exhibition stands there. And what we find is the engagement, because everybody's in a good mood and they're in a kind of jolly environment, they do have a bit more relaxed atmosphere and a great interchange of information. And we find that's very useful in that environment. The problem has been in recent years, they then go back to procurement and say, look, we've identified this great product, and that's the end of the conversation. That's the reality. But certainly it's very noticeable for us when we do an exhibition. We get a lot of interest, we get a lot of first-class conversation, and a lot of good comments like we're getting today. There's a question we've been asked that we don't know the answer to. We'll look into that. It's just valuable to get that level of access that used to be quite commonplace years ago, but isn't now because of restrictions in actually meeting our customers.
Which in a sense is the value of these kind of webinars, because with the reduced face-to-face contact, I mean, if we haven't got very effective ways of sharing good practice or new developments, how is the industry going to be able to support that innovation? So because you have to be as manufacturers or suppliers, you have to be able to do your business, otherwise you won't be able to continue. But how does the health service get to recognize that kind of new innovation or new developments, and how is it makes those choices on whether it wants to invest or move forward? We're very nearly at the end of time. I've got one very practical question, and then I've got a question that came at the beginning, which I think more relates to me rather than around culture, which we might want to end on. But Giuseppe has asked, how many years is the warranty? Which is over to you, Jamie or Stuart.
Yeah, it's a standard 1 year warranty on the devices. Expected lifespan of about 4 years, I think, before a replacement would be required. But if it works, it works. And other than that, just servicing or a battery change, that's all that's required every 2 years. And that's something we'd obviously train the EBME department up to do themselves. They would just buy the stock of the batteries. But yeah, that's it in a nutshell, 1 year warranty.
Okay, thank you. And then Varsha, at the very beginning, I think he, I'm sorry, I don't know, asked the question or made the point about blame culture and leadership. And that comment was made when I was doing my introductory, my introduction on the work we're doing at Patient Safety Learning and the 6 foundations for patient safety. We could have several hours of webinars on culture and safety. I attended a Freedom to Speak Up Guardian stakeholder network meeting on culture and just culture last week, and the question there raises about learning about blame culture and leadership from other industries. And I was really surprised, quite delighted, but surprised to learn so much about the culture change that they've been introducing in some of the banking industry after the financial crisis. So we had presentations from Deutsche Bank about how they've designed and developed programs for culture change within that industry. Not something I knew beforehand around that industry, but I think that there is value about looking how other industries are tackling issues of a toxic or blame culture which prevents learning. And I just wondered if you'd got any final concluding, because we're right up to time, any kind of concluding comments about safety and culture that you might want to add to end today's session on. It's just you didn't know that question was coming, but I don't know, Stuart, whether you want to kick that one off.
Absolutely, I completely agree with that. And despite huge advances in that area over recent years that I've seen, we recently produced a paper on PPE for another product that we're doing. And the CCG leader did actually write a part of the article on a negative experience in trying to acquire PPE throughout COVID-19, but the person wasn't happy to be named and wanted to remain anonymous. And I think that would be the first indicator for me where people are completely happy to be speaking out in public and not remain anonymous. But it's still existing, obviously, so not good.
Dylan, you can comment, but I recognise that that's maybe a more difficult question for you to ask, maybe not answer, maybe not. Is there anything you'd want to reflect on in terms of culture and safety?
No, I just think the safety of devices is a key part of our role, so it's just an everyday thing for us, and it's good to highlight to other people that that's what EBME do, because we're often sort of hidden. I mean, like in my hospital, we're in a porta cabin out the back of the hospital, so a lot of people don't know who we are and what we do. So it's always good to spread knowledge of that. So yeah.
No, thank you for that. Any concluding comment, Jamie, from you?
No, that's all. Just thanks everyone for your good questions and engagement. Yeah, really enjoyed it. I hope you found it informative. Yeah, that was great. Thanks everyone.
Excellent, thank you, and thank you obviously to Rob and colleagues at gov.connect who've helped coordinate and set this up. And as participants will see, lots of files, lots of information. There's an offer there as well in terms of the product, but really do. Oh, thank you, Rob. Rob's just made a comment saying really enjoyed the webinar. Thanks to the team, very informative and a great product. Thank you, Rob, for that. And do follow up everyone with the team from Pendleton Medical. Any questions to Dylan? We could follow through, and anyone that wants to engage actively with us at Patient Safety Learning, we'd love that, particularly about getting knowledge, content, good ideas on the hub, because that's a free resource for people to use. So we'd welcome your involvement and your registration on that. So thank you, and have a good day.
Thank you, everyone. Thank you.
Bye-bye.